Okay. Okay, but today we're going to be talking about bias. Just first general concepts around bias and then bias in fieldwork. But you all know what I'm going to want to be asking of you here. Just a sec, I had my Moodle closed. So be thinking about your 2 words. I really like it. I like hearing from you all, first of all. It makes me feel like we're a little more all a part of things here. So think of your two emotion words for today, and we'll do that in just a sec. All right, I had it up and I closed it. Okay. Okay, so yeah, 2-word check-in. My 2 words today are energetic and positive. And just feeling ready for progress. Okay, in case these help, you don't have to choose from this list, but go ahead and jump in and we'll just do attendance / 2-word check-in real quick.
Deanna, feeling flustered and accomplished.
Puna, I'm feeling hungry and motivated.
Brittany, and I'm feeling very excited and very overwhelmed.
Leah, and I'm feeling tired and relieved.
Madison, and I'm feeling tired and peaceful.
Helena, I'm feeling excited and hopeful.
Emzy, I'm feeling overwhelmed and anxious.
Cameron, I'm feeling antsy and optimistic.
It's Grace, and I'm feeling hungry and a little bit tired.
It's
Jaren and sorry, Julia. You can go.
Sorry, thanks. It's Julie, and I'm feeling happy and hungry.
All right, it's Jaren, and I'm feeling toasty and like the color orange.
Olivia, and I'm feeling eager for spring break and productive.
This is
It's
Jasmine.
Kylie.
Oh.
Go Liliana!
That was so many people. Okay, I'm gonna go. Hi, it's Liliana. I'm feeling content and a little tired. Kylie, you wanna go?
Okay, I'm feeling alive and good.
This is Megan, and no.
You go, Megan.
Yeah, you're going.
Go, Megan, go.
Megan. Did you mute? No.
No, I'm unmuted.
We can hear you. I can hear you.
I'm here. Let's go with that.
Okay.
I'm Molly. I'm feeling tired but motivated.
I'm Bree. I'm feeling thankful and hungry. Sorry, whoever was going.
All good. I'm Lyric, and I'm feeling frustrated but productive.
I'm Ron. Oh, sorry. I'm Kamran. I'm feeling exhausted but hopeful.
I'm Nora. I'm feeling cozy and antsy.
I'm Abby. I'm feeling comfortable and courageous.
I'm Kate, and I'm feeling motivated and busy.
I'm Jason. I'm feeling energetic but a little uneasy.
I'm
Sorry, you go.
Okay. I'm Jasmine. I'm feeling sleepy and sassy.
I'm Katie, and I'm feeling ambitious and excited.
I'm Julianne. I'm feeling anxious and overwhelmed.
I'm Bea, and I feel thankful and relaxed.
I'm Emily, and I'm feeling busy and excited.
I'm Lauren, and I'm feeling tired and a bit unproductive.
I'm Chloe and I'm feeling fatigued and stressed.
I'm Rachel, and I'm feeling confident and annoyed.
For Lauren, who just went, you're Lauren Sua, right? And I don't know if I'm saying that right.
Wrong. Lauren Kreitzer.
Oh, okay. Sorry. Do we have other Lauren here?
Hello, I'm Lauren.
Okay.
I'm sleepy and tired.
Okay. I feel like I saw Cameron. Yeah, Cameron, you're here. Did you?
Yeah, I'm still antsy and optimistic.
Okay, sorry. Yeah. And then is Molly here? Molly. Yep,
Yep.
I see you. Okay. And Nydia.
I am feeling tired and thankful.
All right. Okay. Okay. I feel like good mixes, a little bit of like yin and yang amongst folks, so yay. So let's move on. So the other piece with this talk today is this is a topic that I myself just feel like I'm constantly learning with, and by no means consider myself an content expert on, etc. And I think really that's always the approach with this topic. So I've included a lot of videos and some activities today, so we'll just have to kind of see how it goes, the timing. But then there's some pretty important pieces of information, particularly at the end. So I'm just going to be watching our time, and we might just kind of move through some stuff faster if we need to. But so the learning objectives, I want you to leave here able to explain how bias can negatively impact the therapeutic process. I want you to be able to think about kind of action items for addressing maybe your own personal biases as an upcoming student in fieldwork or as a practitioner. And then also 2 major takeaways that will, again, basically inform you. So thinking about you both as future fieldwork students, but also as an early practitioner. So we'll be thinking through kind of some clinical stuff or clinical implications. Okay, so first, just kind of the overview of bias. So we're all on the same page. So bias is tendency to prefer one group or item over another. This can, be a positive leaning thing or a negative leaning thing, and also depending on how that is interpreted. And so because of that, it tends to be based on kind of stereotypes, things you've digested, and or limited experiences that have kind of limited your ability to look at the scope of something. So every person holds some degree of bias. And there's also what has been determined and labeled essentially as implicit and explicit bias. Implicit bias being that more unconscious bias. So I'm moving fast because I feel like most likely you all have encountered some of this information before in the past, but just so we're all on the same page. So explicit is that tendency to prefer one group or item over another that you're aware of. You may communicate, you may just know that this is, you know, something that aligns with your values, thoughts, beliefs, experiences, etc., and you explicitly are aware of them. And then there's the implicit unconscious things where we show preference without that same level of awareness. So with that can come discrimination. Bias becomes an issue when people start to be treated differently, poorly, and that then leads to the discrimination, right? So biases impacting then how a person is basically showing up and engaging with folks. Okay. So those are just kind of some terminologies. Now I'm going to hand it over to a quick little video that also just kind of talks about basics with bias. So give me a sec here.
So bias by itself is an algorithm of the mind. So it's a complex set of emotions that have become attached to one another that then manifest into the way we perceive, reason, remember certain things, certain incidents, and make decisions. And that's what bias is. Now there's two forms of, big picture, two forms of bias. One is conscious bias or explicit bias, something we know as, racism or sexism or anti-Semitism or even transphobia, Islamophobia. These are forms of bias where people hold conscious, explicit beliefs about other groups, whatever that group may be, whether it's women or people of a certain gender identity or sexual orientation or ethnic group. But then there's a form of bias called unconscious bias or implicit bias. And what unconscious bias is basically ingrained habits of thought that lead to errors in how we perceive, reason, remember, and make decisions. And over the last 20 to 30 years, leading research from across disciplines, from criminology to health policy to marketing and advertising research, has really shown that unconscious bias is one of the leading causes of inequity in our country. First of all, knowing one's bias is really important. So for the vast majority of Americans, we won't say that we're biased, because we're not, actually. Consciously speaking, we believe in the three pillars of our democracy: life, liberty, and the pursuit of happiness for all people, regardless of our color, regardless of our gender, our sexual orientation, our religious beliefs, because those are deeply ingrained values we hold. But when I talk about bias, it's really about unconscious bias or implicit bias. And that's, again, not our fault that we have it, but in the age we're living in, we have all the tools to hack it, to break that bias. So it is something that we have to be responsible for. So the first thing that health practitioners, providers can do is know their implicit bias. So log on to Project Implicit and take a free test that takes 2 minutes to do.
Okay. And we're going to do that in a minute. Okay, so reiterating some of the stuff I just went over pretty quickly. Okay. So I'm just going to go ahead and have you guys right off the bat here just put into the chat thoughts that you have about how implicit bias may affect the OT process. So you can think about it maybe as a different practitioner, a different scenario where you're watching them and you're seeing maybe that they clearly are holding a bias. How might that show up as they move through the OT process? Okay. So I'm going to start reading some of these out. So the way you use your therapeutic use of self with the client and the extent you engage with and can also be affected, right? So it's how you're both engaging, but then also responding, kind of that two-way cycle or process that you're moving through as you go through the OT process. And sorry, good job, guys. Hold on, I gotta make this bigger. Okay. Yeah, love it. Not giving equal care to every client. Absolutely. Having feelings about someone and change the way that you handle care with that person. The questions that you ask, that's such a nice point. Yep. And you can see how these are things that you might be doing that you don't even realize, right? But you're just maybe not asking certain questions, or you're asking certain questions that you otherwise wouldn't with others. Definitely. The type of interventions you decide for the client, absolutely. We'll talk more about that later. Types of interventions, questions, good. You all are all kind of on the same page, definitely. Assumptions about education, experience in healthcare system, absolutely. Great point. We'll speak to that. Believing people are naturally good or bad at something based on their appearance, absolutely. Preventing OTs from understanding another's culture and not tailoring occupations towards the culture. Absolutely. And I have an actual literal case example of that we'll talk about later. You could just totally right on. Might affect what assessments we choose or use with an individual or what goals we think are best for them, problems we identify. Yeah, so you can see it can really touch every aspect of your OT process. Your culture that you're just coming from, your lens, absolutely. Assuming a client may be harder or difficult because of any type of group that you may see that or you may be putting them in, definitely. Therapeutic relationships, absolutely, and that's huge. Changing the way we view something may be a cultural norm for our client, but then we see it as something that needs to be changed or addressed. Absolutely. This is so huge. I worked in pediatrics, and there are big differences in expectations and what a child should be doing at different ages. Like, you probably have talked about it in peds, but it's really fascinating. And it's something you have to kind of keep in mind and be checking in as you go through your OT process. Interpreting assessments, absolutely. Documenting words that you use, pronouns, caregivers versus parents, absolutely. Love it. You guys are so amazing. I'm so excited for you to go out into the clinical practice settings. These are all just really good points. And then that's where I come to, there's like levels to this though, right? Like you can be aware that these can be problems, but then certainly you may show up in a certain situation just not perfectly. And so it's something we just always have to be kind of working on and aware of and taking feedback from others with. But yeah, awesome. Okay, so let's keep moving through. Sorry. I use hot corners on my laptop. Okay. Cognitive biases. So repetitive types of thinking that can lead to incorrect or unhelpful determinations. So there's lots of different types of cognitive bias, and you all were getting to that in some of your responses that you just talked about just now. And these are the ones that can be kind of really hard to identify because it's more kind of your way of thinking. And less about like an actionable thing about like whether I'm using pronouns or whether I'm remembering to ask about things like that, whether I'm using the right semantics. Cognitive biases are more those like assumptions that you're making, right? It tends to be to be that. And then with that comes confirmation bias. So when someone's cognitive processes tend to look for certain information that validates how they already feel. Some of you all had mentioned kind of tailoring your interventions or even interpreting your assessments based on assumptions you're making about how that person might show up. And then the confirmation bias is you're identifying, and your brain is very quick and apt at like logging all the stuff that's going to confirm, your expectations, right? So it's this vicious kind of cycle that you can get trapped in. And that's where collaboration and pulling in, input and teamwork can just be a huge asset in kind of trying to break that a little bit. Okay, so wait a minute. This is a risk. Oops, nope, forget that. Continuing on. Okay, effects of bias in healthcare. So literally, I'm sure you all have maybe seen some of this, but there have just been kind of crazy studies that have come out that are really showing that this is a big problem in healthcare that can literally be measured. So this is, there was a big publication that came out in Lancet, but it was also picked up by, I think, the New York Times or something, and made into kind of a little more like easy language to digest. But this was kind of talked about for a bit when this came out. So there's a big systematic review that Lancet did, showing that children in minoritized racial and ethnic groups receive inequitable health care compared to non-Hispanic Caucasian children. And it was just crazy, all of the different outcomes and implications that they were identifying in the systematic review of just a huge base of literature. So some examples being children were less likely to have diagnostic imaging done in one group versus another. They were more likely to have complications following surgeries. They had longer wait times in emergency rooms, less likely to be diagnosed with a developmental disability, and less likely to be prescribed needed pain medicines. I have heard literature around the pain medicine prescriptions for kind of adult populations, but honestly, this is the first time that I had seen that this really translated also into pediatrics. So just really pretty, I don't know what the word is, but yeah, important to see that, this can easily be measured, which is upsetting. So though there are many reasons that can contribute, researchers indicate the roots of this disparity. So yeah, so they basically are able to also see that structural racism, inequitable policing practices, and disparities in access to financial opportunities and safe housing are all basically contributing factors that they were able to identify in this one certain study. And then a big one, and what we're touching on today, is that piece of implicit bias in healthcare providers, just across the board. Okay, so you all, I think, touched on all these already. I'm impressed by just the scope that you were all able to touch on when you're thinking through how this can impact the therapeutic process. This was just kind of a little article in Psychology Today, and speaking a little bit more to some of the specific groups that traditionally can be marginalized or receiving bias, that they basically were speaking to. But yes, another one that maybe wasn't specifically spoken to is assumptions about drug use, based on socioeconomic status, location, living conditions, and race. Beliefs about life based on assumed gender, age, and race. So kind of assuming what their life may look like based on those factors. And again, this is so, you can imagine why this is so, I don't know if important is the right word. It has so many implications in what we do as OTs, because we are looking at these things. We are factoring these things in. And so then if we have biases that we're drawing, because we're taking the time to put our awareness to like write like all the factors of a person. But then when bias is tied to that, it can be really problematic. Okay. So more things that came out of a study in Tennessee. Assumptions about being a patient being inactive. So someone spoke to that a little bit in terms of kind of how a person maybe appears or looks. You know, you think about some of our more like rehabilitative model type therapies that we might do. There can be implications to how you put together a plan of care, expectations, goals you set. We spoke a little bit about treatment of pain and assumptions about pain experience that can differ across groups. And then this one too, I think is important to keep in mind, assumptions that certain clients are more passive with their healthcare decisions. So they were able to see that there were assumptions and biases between some different groups amongst healthcare providers, just about kind of how engaged they are going to be in their healthcare decisions. That's a pretty sweeping big thing. So okay, so this is what I was saying I was going to read through. I just think it's kind of interesting. It's kind of a little bit of a case example, and it's a case example, it's a fieldwork situation. So a student who identifies as Chinese starts her fieldwork rotation at a busy inpatient rehab unit. The student completed the first semester remotely in China and has never been in the United States prior to starting fieldwork due to COVID-19 restrictions. The student observes the supervisor during a session on ADLs and offers to help. The supervisor responds to the student by saying, "Don't worry about it." The student re-offers help, and the supervisor repeats the phrase, "Don't worry about it," with a visibly dry facial expression. The supervisor never discussed the incident with the student afterwards. So this kind of, by the way, subnote gets back to our thing about feedback, right? While completing the fieldwork performance evaluation, the supervisor describes the student as does not respect professional boundaries and cites that incident where the student had repeatedly offered help. But then while discussing the fieldwork performance evaluation concerns with the academic fieldwork coordinator back at her school, the student describes that in Chinese culture, you are expected to offer help to authority figures, even if the other person declines, because they are most likely trying to save you the trouble. So someone had spoken to kind of assumptions you may make and just not understanding maybe cultural practices or assumptions or beliefs that may implicate how a student shows up, how a fieldwork educator shows up, how your client is showing up and engaging. So yeah, so this is just an example of how the fieldwork educator, right, kind of essentially misinterpreted or just missed an opportunity mostly to just kind of understand there was a cultural competency that she was missing that would have that would have explained the student's behavior instead of marking it as a problem, right? And certainly it's an opportunity then to talk to the student about how, well, you know, as you're engaging with other professionals, this is how they may interpret that if you do this behavior, right? So it's a miss of a learning opportunity too. So anyways, I liked that example for you all because it also shows, and this can go both ways. You know, you all might have fieldwork educators that have like a cultural identity or a way of engaging with folks that you might need to kind of familiarize with, ask questions, just so everyone can kind of be learning and identifying kind of where the misinterpretations might be, biases might be. Okay, so another quick video, how implicit bias affects healthcare, just kind of in the broader scope, just driving home this point.
So in healthcare, bias comes in various forms. And I would say there's three primary ways that we could actually track bias. One, of course, is in interpersonal interactions, let's say between a patient and a provider. So the unconscious ways that we may have associate certain groups, certain gender identity, people with certain gender identities, people from certain racial or ethnic backgrounds, manifests in the diagnoses we're making, the interactions we're making with the patients, as well as the warmth with which we're working with them, which impacts the amount of trust that they have in the providers themselves. How does that manifest? One of the major ways that's been studied and shown and reported over and over again is pain management. So patients with darker skin, African Americans, receive lower dosages of pain medication across the board, from infants to the elderly, for the same types of ailments they come to practitioners for, because of assumptions that are being made around addiction or their ability to actually be truthful around what they're experiencing. The second way bias really plays into all of this, particularly unconscious bias, is the internal dynamics of organizations, how employees and staff members communicate with one another, team collaboration, team dynamics, but as well as performance reviews, reviews around compensation, who gets to be promoted, who gets to be a leader of an organization, of a team, based on assumptions that we may have about those people, purely based on phenotype, their origins, whatever that may be. And the third way bias really plays out in healthcare, and this is, quite well documented across the board, is its costs, wasted costs. So racial bias, just one particular identity that we're concentrating on, costs the US economy, the healthcare system, $310 billion a year. And for me, I just want to think about what can we do with that money if we didn't have bias in the world.
Okay. So I'm going to move on to, sorry. Okay. Have all these different windows. Okay, so addressing bias, I mean, essentially it's something that we just kind of always need to be working on. And essentially, these are ideas, but about how to go about it. I think the overarching thing is just to maintain a curiosity mindset, and to always go into something, whether it's client to student, or fieldwork educator to client, all the different interactions that you may have, just with an open curiosity and asking questions. Okay. The last point was the thing I thought was kind of the biggest takeaway for me from this article. So you can, again, for myself, these are things that I've heard, except the last point. So of course, finding time to spend time with people who are different from you, or, thinking about characteristics that stand out from people that may be outside of groups that you tend to group yourself with, etc. But the last one I liked. So utilizing self-compassion and self-care, as implicit bias is more likely to appear when we are not at our emotional best. I think that this is a really nice, important piece, especially as we go out and be practitioners, especially as you go out and start engaging in stressful clinical situations. I want you all to kind of really digest that and register that, because as you become more stretched, your implicit biases are more likely going to show up, and it's a lot harder to manage. So I think it's a really important thing to keep in mind. And then also is just a nice reminder of why we should always all keep working on ourselves so that we're ready to show up how we want to in the workplace. Okay. So it is our responsibility. We talked about our code of ethics, etc., to always be trying to address and overcome biases in any way we can. And yeah, and just be learning about words or automatic reactionary responses that you might have, and just try to fold them into how you show up as a practitioner the next time. Okay, the next thing I wanted to show you all, I thought it was interesting, and I'm mostly curious to hear your thoughts about this. Because honestly, going into how to like really address this topic well, it's not an easy thing. I've been telling you guys, I've been trying to think about it. And I just saw that this is done actually at my alma mater. They are doing bias training through VR at the Columbia University OT program. And there are some other like MD programs and medical programs that are also using this. So I just wanted, oops. And they have a nice little video where they interview some of the OT students. So I just wanted to share that. And then I wanted to hear all your thoughts afterwards, because I might try to get something similar here.
Being a person of color, because I know that at some point in my career, I would probably experience some kind of discrimination or just something where we're not seeing eye to eye culturally. I thought I was prepared for a situation like that. And the virtual reality simulation kind of showed me that I wasn't as prepared as I thought I was.
Here at the Columbia University Irving Medical Center and in the occupational therapy programs, we value our mission for diversity, equity, and inclusion, and specifically inclusive teaching. For that, we received a grant from the Provost Office for Teaching and Learning, where we use virtual reality with the help of the emerging technology team, using the software called Equal Reality to complement a course in our program, which is new course in the curriculum that we're really excited about, called Diversity, Equity, Inclusion, and Professional Skills.
We learned a lot about intersectionality and being able to view a person as a whole. And I think especially for the field of occupational therapy, where we're very client-centered, it was really nice to be able to kind of break down those biases and kind of promote cultural sensitivity and humility. And that was done through all the VR.
This project will help the students practice these skills that they need to address bias, discrimination, microaggression, while they are occupational therapy practitioner, and one day when they are interacting with clients and their families and other healthcare professionals.
I think the virtual reality gives you the best experience and the most realistic sense of what you will experience in the real world. I don't really think it could be recreated through any other form of teaching.
One of the great things about virtual reality is students get to learn about bias and microaggressions on their own pace without feeling the pressure of interacting with another classmates in the moment or the needing to articulate their thoughts on the spot.
In the VR experience, it starts off with a mirror in front of you. And in this mirror, you can move around and you are a different person. Whether it is a person of color, a person of an older age or a younger age, it starts to psychologically trick you into thinking that this is who you are and this is who you are in this experience. So it gives you a lot better of a perspective when you start to go into those situations and the simulation to really start to feel and empathize with that person that they are portraying for you to be.
You were able to press as many times as you felt that bias was happening, and as I kept pressing, I kept feeling that bias was occurring, and you see afterwards how many buttons you press versus how much bias actually occurred. And I wasn't even close. And it's just a good chance to reflect on your own bias and see where you could change.
After they're done with that technology, we open it then to class discussions and group discussions, which will allow to a deeper conversations. I'm grateful for this experience because it gave me light into something that I'd never had before. And I know it sets me apart from other future clinicians because I'll have this perspective that maybe others didn't. And it'll let me be able to communicate with my clients in a more open and respectable way. Columbia University has a mission towards teaching excellence. And following that, we are leading the way for the profession to use virtual reality and technology. We are the first program that does that in the profession, and there's only more to come and the use of more technology in our courses.
Sorry, it's also kind of plug for Columbia, of course, but yeah, okay. So show of hands, do you all think that something like that would be helpful for you? Would you be interested in doing that if that was an option here? Can you like do a little like hand raise? And then I don't know. I might look into this. Yeah, maybe.
I guess I'm a little confused, like about exactly what it's doing. I don't feel like
right.
it was totally clear what the goal was. I don't know. Yeah.
Yeah. No, agree. I'm sorry. Yeah. And from what I can gather, I mean, there's a few different things that can be done, but essentially the first thing that they have you do is you go through kind of like the process of being admitted into like a clinical setting and engaging with a medical practitioner. And I don't know if Columbia is able to like tailor it to more of like OT type engagement and activities. But the idea is, so if we have time, I'm going to have you all, you may have done, Harvard has the implicit biases tests. Have you all seen that before? So I think this is like a VR version of that essentially. It's like a way you heard that one student saying how, you know, they're supposed to press a button every time they are perceiving bias, and then you compare that right against the actual supposedly biases, incidences, just to give you insight to as to how well you are perceiving and catching things. So yeah. You get Kaylee's done it many times. Yeah, so that's been an activity we've historically had you all do in this seminar, but I'm going to give you a break. I'm going to see how we're doing on time. We might do that, or we might look at a few more videos and just do some talking, but take a break, y'all. Sorry, time went by here. And let's come back. Oops. Let's come back at 3:35, 5-minute break. Okay, see you soon. Okay. Okay, you all, let's just keep moving along here. We're doing pretty good at time. There is one last just part of a video here that I'm going to share where they speak more to kind of what medical professionals should be doing to address bias. So, sorry, I should have this. And I'm sorry, Rachel, thank you for pointing out that I keep saying Kylie's name wrong. I'm so sorry, y'all. It's, yeah. The problem is I read your name wrong and then it gets stuck in my brain that way because I'm not seeing you all in person enough. So please continue to correct me. Yeah. Okay. So I actually want to fast forward this to, sorry. Okay.
Providers can do is know their implicit bias. So log on to Project Implicit and take a free test that takes 2 minutes to do.
Okay, so I've decided we're not going to do this test. I feel like you all have probably seen this, and it's linked in the slides if you want to check it out. It's kind of interesting, but it's kind of intensive process too. And I would rather get to the important part at the end of this, where I'm going to talk to you all about if you're out on field work, kind of action steps to take if you are seeing bias happening or if you're experiencing it yourself. So I'm going to just we're going to skip that for now. But it's something that you can definitely check out on your own time if you haven't done that and if it's of interest. Okay. Oh, I'm sorry. My hot corners are giving me issues. Okay.
But really see where on the spectrum do you fall with respect to racial bias or gender bias or sexual orientation bias or age bias. So we become aware of, wow, this is how my mind, my brain is primed to see people. And this is how I'm making split-second decisions. That's the first thing, right? The second thing is really looking around our friends and family circles. Unfortunately, we're still living in an economy where less than 9% of our physicians and less than 15% of our physicians and our nurses and nurse practitioners are of color. And when I say of color, really primarily African-American, Latino, and Native American. So these are really small percentages. For a country that's over a third African-American, under 10% of those practitioners that are providing to those communities that may come from those communities, may understand the experiences of those communities, are not from those communities. This doesn't mean that we can't provide equitable care to those communities. Of course we can. We have that potential, but we need to hack bias to do that. And one of the primary ways of hacking bias is social contact. So look around and do one thing. Notice who are our intimate friends? What's their background? What ethnic background do they come from? What's their histories? And just literally do that self-reflection. You can even write it down, map it out. So you know in your own inventory that, oh my gosh, most of my friends are Black. Most of my friends are white. Most of my friends are Indian or Asian or Muslim, whatever they may be, whatever the identity is. They're gay or straight. Because that way you know that that's the community you're living in. And that's the community you're relying on to carry on. So taking that inventory check. And third, invite the other to dinner. So literally seek out, if you feel like you don't have a diverse group of friends, people that you really can share something with, make one. And how do you make one? Starting with a coffee or a lunch. But in that coffee or lunch, ask them 2 questions. And this is really important. Ask them the following 2 questions. And tell them your own answers to these questions. What breaks your heart? What makes you come alive? And see where that goes.
Okay, so I mostly liked this video because of that last part, because I felt like that was really actionable, because this things that I've heard before, right? We even had it in like earlier slides, like look at who's around you, you know, try to, but I really liked how he gave these questions that you can see might elicit something deeper and something so much more contextual to a person's lived experience, which is what we're trying to get at, right? With kind of meeting lots of folks. So I liked it for that. Okay. So we have in the past had, we had a student that did their capstone kind of around these, around bias and such in, as clinicians. And so I inherited essentially some quotes and experiences that this student had acquired. And I thought they were interesting, so I'm going to pass them along to you all. So related to experiencing and addressing bias in the workplace. So first, these kind of quotes are going to be experiences of, I think it was an OT that had worked about 3 years in the workplace, and some of their experiences and just thoughts from that this student had elicited in their capstone project, I believe. So the first one, I do wish that these workplaces had a more explicit policy or program in place that state their support, provide a resource to employees with marginalized identities, and articulate not just their legal responsibility to protect their employees, but also a company culture that welcomes and celebrates a diverse employee pool. There's a lot of talk about needing to bend ourselves to serve all types, in parentheses, of clients, of patients, but less talk about our right to feel safe at work and not attacked for aspects of ourselves that patients might not like. So we've already, okay. So we've already touched on some of these. So potential examples of biases in fieldwork and the workplace. But some of these are a little more specific. And I'll just touch on all of these just to kind of drive home all of the different ways in which you might be seeing this when you go out in field work and when you're in the workplace. So clients mistreating their providers in the form of racial slurs, physical assault, etc. Clients refusing care from particular providers. Fieldwork educators exhibiting bias towards marginalized students. And then also their expectations for student providers to kind of code switch or prove themselves by working harder. Marginalized students receiving different treatment from coworkers. So that might be, you know, other professionals adjacent to the fieldwork educator, etc. So again, just going through these to just kind of flag them in your brain, because these are all, as we go into kind of actionable items that you can take in seeking support and such, these are all the different ways in which that might show up for you. Okay, so another quote from that same study, and again, it's the same person with, it's an OT with 3 years of work experience. If there's someone we could not work with, any of our coworkers would take that person on their caseload. So they're saying that kind of the culture of the site was that if there's someone that like was causing an issue, then any of the coworkers, you know, they would step up and they'd be like, oh, we'll take that person on my caseload. But then returning to the quote, so, but again, there was still no formal pathway in place when it came from patients. There was nothing in place to protect me or anyone else when I got slapped by a patient or asked if I spoke English or when my Black coworkers were told horribly racist things. So they're saying essentially the culture, the approach was kind of after the fact, right? Of, okay, now we'll, you know, try to avert you away from potential harm in the future by maybe putting a different therapist, putting a person on a different therapist caseload. But this OT had noticed that there just really wasn't any pathways or things in place to both prevent and immediate actionable things for them to do if any of these horrible things did happen. So a quick little excerpt from a study. Experiencing discrimination and bias undermines minoritized students' feelings of belongingness and autonomy, which has in turn been linked to the detriment of their academic performance, persistence, and educational success. So there's definitely evidence that this can be at the detriment to your success as a student. So we take it very personal, or not, we take it very seriously, and we will do everything we can to support you. And then this is just speaking to kind of the cycle that can happen, and this can happen to you as an early practitioner too, to just be aware of, and it can lead to burnout and turnover, etc., when these systems are not in place to offer support. Okay, so we don't have a ton of time. I'm going to skip something. Okay, so just flagging for you all, as you go out on the sites, I want you to start kind of seeing and thinking about this, and also seeing and thinking about it so maybe you're ready and feel ready to reach out and use supports that we have tried to put in place where maybe sites might not be. So organizational efforts that can help. So reporting systems. Do employees know how to report instances of bias or discrimination? And what does follow through look like? Is there bias training? Safety category. Is there someone students or employees can talk to following an event, especially an event that was unsafe? Are there safety personnel and systems in place in case of like an emergency? So settings where this, for instance, will most likely will be in place and that you will be trained up on would be maybe like an inpatient behavioral health setting. They're going to have pretty systematic ways to go about this. But, you know, make note that maybe in other sites, it's not as explicitly gone over. And then, so dedicated roles, having kind of dedicated roles in clinics and centers. So centers for diversity and inclusion, which of course we know are being targeted at the moment. So honestly, I think one of the fallouts might be that we just start labeling them maybe in a little different name, but hopefully those things will still stay and exist. Title IX coordinators and offices. These are just examples of these types of kind of dedicated roles and spaces for addressing these things. Oops. Okay. And protocols, is there protocols? Organizational relationships. So that's where we come in. Are fieldwork educators and organizations aware of programs, values, expectations, processes? This is where, you know, you can pull me in, and I will specifically be your advocate, but I also will be saying that, you know, the expectations that we have as an institution as specific. And if the site is not in alignment with those, then we're going to have to problem solve, basically. And then dedicated roles that you have are, we definitely have, I will show you, we have a whole team that is in place to address diversity and inclusion and safety. And myself as your fieldwork coordinator is an advocate for you. And then also your faculty advisor / mentor. So these are, I'm going to go through them in a minute, but you can use any or all of these avenues of support on whatever you feel the most comfortable with. And this is just touching on, you know, we talk about person, environment, occupation, performance model, and this really is a good example of where bias comes through, right? So I'm going to keep going though, because we have important stuff to cover. Okay. just more stuff on what to look for, again, in just departmental culture, environment, things to let you know and to take note of. Okay, so sorry, I'm rushing because this is what's important. I want you to know what to do if you experience bias, a hate incident, or are seeing that and feeling uncomfortable. It might not be directly to you, it might be adjacent to you. There's a lot of scenarios. And so really there is no right or wrong here. It's more just a matter of knowing that you have different resources and avenues to reach out and get the support that we as an institution want to provide you. So the first most general one is just knowing that there is basically what we call the bias/hate reporting system. And this is in the form of a document that you would submit, and it is completely up to you. So this is a choice, this is an option for you. But essentially, there is a team that will take the report and then work with you collaboratively to kind of pull in resources as needed. I don't know if you can see at the bottom right now, Pacific has this little warning that due to staffing shortages, response might be delayed. I have talked to some of my fellow faculty here, and they actually have been impressed with how quickly the response has been and the supports have been anytime something has been reported or something has come up. So they didn't feel like that matched what this warning is. So I guess my message to you is don't let that deter you. And Rachel, I see an interesting comment that I'll get to here. But I'm gonna keep going with this now that I have my brain around it. So thank you. Okay. So just to the more specific, so what happens when you submit the bias incidents report? So first of all, so the bias incident report goes to a team that evaluates the report and then kind of collaborates to develop an appropriate response. So by collaborating, that means they will reach out to you. They're definitely going to be signaling and discussing with you kind of avenues and supports that you want to pull in. So it's definitely, that's where the collaborative piece comes in. So some ways in which that might happen is they may provide care and support to community members negatively affected. So this might be where you're reporting an incident that was maybe parallel to you, right? So it wasn't an incident directly to you, but it's making you feel uncomfortable or something that is happening at the site, like the culture of the site. So that's an example of that. And so they would think through and they would, of course, pull me in on how we can engage the site in an appropriate manner. Learning more about the incident, they'll just, as much as they're comfortable, of course, gather more information, dialogue, interventions, etc. Access to referrals on campus and resources, so they would help you just make sure that you know all the resources that might be relevant to the case and help you reach out to those. And then again, similar to kind of the reaching out to community members, coordinating efforts to restore individuals and groups that were negatively affected. So just really taking that holistic approach. And then timeline just depends on the complexity of the incident. You can just think of it literally as just kind of like a team of support. So, and then they will also do a follow-up with you just to make sure, say they have given you supports and resources, they definitely will then be kind of circling back and checking in, etc. So it wouldn't be just kind of like a one-off thing. It will be more of like a teamwork situation. Okay, and again, this is all also basically published on the site too. So, but I just wanted to go through kind of the main points. So the reports are basically, they definitely are used to kind of summarize the incidents and help the team kind of determine what needs to be done. Reports may be routed to human resources, student affairs, academic affairs, etc. as appropriate. But from what I understand, they definitely would be in communication about that with you. We do, of course, use the reports too to inform choices about future, fieldwork education sites, for instance, if it were the case for you all on a fieldwork, prevention programming efforts, more supports, more different specific departments, etc. So we use it as an institution to inform, any changes needed. They list some types of bias that are included. Privacy, so persons reporting the incident may self-identify or they may remain anonymous. So if you put in your report, you can do it anonymously, but I know they always just say the caveat to that is, so if you're anonymously reporting, you are essentially helping us as an institution, right, to be aware and to make changes that would be relevant. But then if you self-identify, that allows us as an institution to then offer that more specific support to the incident. So that would be just a consideration for you. Okay, so again, these supports are cited on the bias and hate reporting site. I have linked that site on the Moodle. There's a direct link to that site where there's the form, and then all of these resources are below. And so to end, AOTA vision of 2025. We are intentionally inclusive and equitable and embrace diversity in all its forms. This is making me emotional. I don't know why. Okay, sorry. Okay, that's embarrassing. I'm sorry. Okay, I'm gonna stop recording. Okay, so that is everything. Okay.